el estudio Timeless que está en curso en este minuto. Doctor Albers.
Thank you. So for all our careers, we've been very used to the idea that there's a strict time window for IV thrombolysis. 3 hours for many years, and then it went up to 4.5 hours. And what we'll be talking about now is that in the future, we are not going to have a strict time window for IV thrombolysis. So let's see here. Part of the reason that we have the strict time window is that the trials that have tried to go beyond 3 or 4 hours have failed in the past. And there have been many, many attempts to do this. So if you start with the streptokinase trials, the first 3 trials on there were streptokinase trials that failed. And then the Atlantis A and B and the 3 ECAS trials mentioned were trials of IV TPA that failed. And then more recently, there were desmoteplase trials that tried to go to the late window, and they failed. And the reason that they failed is shown in the graph, which is the typical down slope of good outcome over time. So this is looking at the treatment effect of the IV thrombolytic versus placebo. And you can see that the treatment effect is very robust in the first hour or 2, and that goes down, 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 and it fades away. So how can we get to the point where we have successful late window IV thrombolysis? Well, the answer is with imaging. And we now have a couple of trials to talk about where instead of all this negative, we now have positive results. So it's important to separate these 2 trials because they're very different in what they looked at. The wake-up trial really was not a late window trial. The wake-up trial was a trial of identifying early window patients who woke up from sleep. So you're probably familiar with this trial because it's been out in the New England Journal for over a year now. And what they did is they took advantage of the fact that if you do an MRI scan and you look at the flare and you don't see any lesion on the flare, but you do see a lesion on the diffusion. Microphone's not working. Is that better? Yeah. So again, this is a trial of wake-up stroke patients. It's not a late window trial because in particular, the whole idea of the diffusion flare mismatch is it's going to identify patients who are in the early window. It's going to identify the patients who had a stroke in the early morning hours before they woke up. The other thing about this trial that's important to know is that there were very few patients with middle cerebral artery occlusions. Only 1/3 of the patients had any vessel occlusion on the MRA, and most of these are smaller branch occlusions, like M2, M3 type occlusions. Small vessel occlusions are the ones that are most likely to respond to an IV thrombolytic like TPA. But this is the first positive trial where we can treat patients who woke up from sleep with TPA, and you can see the benefit. The primary outcome was statistically significant. Unfortunately, there was an increased trend toward more death in the TPA versus the placebo group. And as you could imagine, there was a trend toward more brain hemorrhage in TPA versus placebo. So overall, it was a positive study. Places that can do MRI have been using this, but it is not the answer to the problem in general. A much more important study is brand new. It was just May of this year in the New England Journal, and it's called the Extend study, because this is the first trial ever to show that people who are actually in a late time window, witnessed to be beyond 4.5 hours after symptom onset, can benefit from IV TPA. And the way that this study was positive is the same way that I've been showing you from SWIFT Prime, Extend IA, Dawn, and Diffuse 3. This was using the RAPID software to identify patients with penumbral tissue. So the penumbral tissue hypothesis works both for IV thrombolysis as well as for thrombectomy. So let's take a deep dive into this trial, because as neurologists, you need to make a decision whether this trial is compelling enough for you as a single trial to start using IV TPA up to 9 hours after symptom onset, because that's what it was. It was a 4.5 to 9 hour window, and it had selected wake-ups. So the type of patients that were enrolled in this trial were your typical elderly stroke patient. We're looking at mean age in the early 70s. The type of patients who come into an IV TPA trial will have less severe strokes than an endovascular trial. So here we're looking at NIH stroke scales around 11. And you can see that these patients, about a quarter of them were documented to be within 6 to 9 hours because they had witnessed onset and they were 6 to 9 hours later, but a high percentage of them were wake-up strokes. So the way the definition in this trial worked for a wake-up stroke is different than what you're used to. Normally a wake-up stroke is you time it from when they went to bed. But here, they timed it from the midpoint of their sleep. So if they went to bed at midnight and they woke up at 8 a.m., the time of onset was 4 a.m., halfway between when they went to bed and when they woke up. So based on that timing, if you were within 9 hours, you were eligible for this trial. And many of the patients came in with that type of criteria. Okay, so the median time from last known well to therapy was about 9 hours, right? So that's pretty late. And it's really important to know this trial had a high percentage of large vessel occlusion. 70% of the patients here had large vessel occlusion. This is a very big difference between the wake-up trial that had a very small percentage of LVO and this trial. So what's the problem here? The problem here is that there was no rescue thrombectomy. And we know that thrombolytics are very good with M2s and M3s. They're not terrific with M1s, right? So that tells you from the start that this trial is going to be limited in having a very high good outcome rate because the TPA alone is not going to dissolve a high percentage of the M1 occlusions. But despite that, this is a positive trial. And this is, again, the first ever late window trial to show positivity. And remember, I showed you 11 earlier trials that tried and failed. So this is unique, and it's the unique approach to identifying salvageable tissue. So here's the primary endpoint. It is a increase in the rate of full recovery, right? MRS is 0 to 1 at 90 days, and you can see that there was a benefit, but it barely reached statistical significance. This is not a huge impact study like Diffuse-3 or DAWN or some of the other thrombectomy trials. It is a positive study, but it is a smaller benefit than what you would obviously see with an endovascular trial. So you saw the primary outcome that had a P04 value. Here are the secondary outcomes. If you look at MRS 0 to 2 at 90 days, that was statistically significant. The shift in the MRS score was not statistically significant. Early neurologic improvement was highly statistically significant. And take a look at reperfusion. You can see that here's part of the problem, that at 24 hours, that you can see that it's not a high percentage of the patients who are getting full reperfusion like you would see in an endovascular trial. Recanalization, 39% in placebo, 67% in TPA, but that's at 24 hours. And in the early time points, it's going to even be less. So it gives you the idea that the one component that we're missing here is the thrombectomy to help out the TPA. Okay, so you can see this is a positive trial. Is it enough to change your practice? Well, there's one additional piece of data here that I think will be helpful as the neurologists make the decision. Am I convinced enough by this single study that I should start giving IV TPA to extend eligible patients in up to 9 hours after symptom onset? This is a meta-analysis that was presented at the European Stroke meeting just a few months ago. And what they did is they took 2 other trials that had perfusion imaging for late window TPA treatment, but they allowed people to get in who didn't necessarily have a mismatch. The ECAS-4 trial was not using any automated software. They were doing perfusion, and then people would eyeball the perfusion map. And when those cases were run through the RAPID software, only about 50% of the patients had the target mismatch. Same thing for the epithet trials, an Australian trial that allowed you to get in regardless of mismatch profile, and then it was later run through RAPID to identify who had a target mismatch and who didn't. So this graph that I'm showing you is all the patients from Extend, ECAS4, and the epithet trial who run through RAPID software and have that target mismatch profile. So they have a mismatch ratio at least 20% and at least 10 mLs of penumbra. And this is a much more statistically powerful result than ECAS, than Extend alone. You can see this is a very nice shift, a larger benefit on the 0 to 1. And you can see that there is no increase in death or severe disability. There's a very tiny trend toward less death or severe disability. What's impressive about this is when you compare it to the patients who were run through the software and found to have no mismatch. So these are the no mismatch patients below. What you can see here is evidence of harm. If you look at the patients who had a favorable outcome, there are fewer patients in the TPA group than the placebo group. And most importantly, take a look at the under end of the scale. The severe disability and death is increased in the TPA group. So this gives you the answer to why those 11 trials that I showed you at the beginning were negative. You're mixing the group on the bottom with the group on the top. And when you mix the group that's harmed with the TPA with the group that has substantial benefit from TPA, overall you get no benefit. That's why all those trials were negative. And this is why the Extend trial is positive, because it's identifying patients with penumbral salvageable tissue. So people are now struggling to say, do I change the guidelines? Usually to change the guideline, you want 2 trials. That's why we really wanted to see Dawn and Diffuse happen, because a single trial, people can be skeptical. This at least gives you data from 3 trials to suggest that if you do this meta-analysis, you get a nice, robust effect. And some of the guideline committees are beginning to lean toward giving the recommendation to go ahead out to 9 hours with IV TPA if you meet these penumbral imaging criteria. In the US, the committee is struggling with this, and they have not yet made an adjudication. So we're waiting to see what they think. But remember, the limitation of these trials, in all 3, no thrombectomy. So that's what we're going to get to next, which is the idea of late window thrombolysis in combination with thrombectomy. And then the question is, what's the best thrombolytic agent? Is TPA really our thrombolytic for the future, or should we be thinking about tenecteplase? Tenecteplase is a sister molecule to TPA. It is only 2 kringles that are different, but it has higher fibrin specificity. And one of the biggest advantages of TNK is it's a single bolus. This is very important for drip and ship, right? Rather than waiting that hour for the TPA infusion to go through before you get on the ambulance, here you give the TNK bolus and they're immediately on the ambulance. So that's a big advantage. And in addition, there is the potential, although not definitively proven, that the recanalization rates for M1 occlusions is higher with TNK than TPA. Okay, so what are the data? So Mark Parsons in 2012 did a study comparing TNK to TPA in the earlier window patients, and although it was a small phase 2 type trial, it appeared to be safer and more efficacious. A big trial called NORTEST from Scandinavia found no benefit of TNK at a higher dose versus TPA, but these were mild stroke patients who in general did not have large artery occlusions. And the most exciting data came from Bruce Campbell in the Extend IA TNK trial, New England Journal 2018, where he did a head-to-head comparison of using TNK as your bridging thrombolytic on the way to endovascular therapy versus TPA. So I want to show you the results of this trial because I think it's potentially very important. So these were patients, early window patients, getting thrombectomy. And as in most cases, you're going to be giving TPA, it's running in as you're rushing your patient into the thrombectomy. So these are patients randomized 100 to TNK is the bridging therapy versus TPA, which is alteplase. And what you can see here is that that 20% of the patients, by the time the endovascular therapy did the initial angiogram, 22% of the patients, the M1 occlusion was gone when the TNK was used as the bridging therapy, compared to 10% with the standard TPA. Right, so that's compelling data. You can see the p-value there, it's 0.02, and what it suggests is that twice as many MCA occlusions were recanalized by TNK than TPA. In addition, if you look at the outcome, so here's the clinical outcome at 3 months, and this is not something that they expected, but there was a statistically significant benefit. It was modestly statistically significant, showing the outcome was better for the patients who had the TNK plus the thrombectomy versus the TPA plus the thrombectomy. So that type of data is what convinced us that TNK is the better choice to move into the timeless study. So the timeless study is really the marriage of what we learned in Diffuse 3 from what was learned in Extend IA-TNK. The study design is virtually identical to Diffuse 3, with the exception that we include M2 occlusions, which were excluded from Diffuse 3, and prior to the thrombectomy being done, the patients are randomized to TNK versus placebo. So what this is going to do is potentially extend the IV thrombolytic window to 24 hours. It is a 24-hour study, 4.5 to 24 hours, based on the Diffuse 3 rapid finding of salvageable tissue, penumbral profile, and we're using the 0.25 milligram per kilogram dose of TNK that was used in Bruce's Extend TNK trial. So the study has been launched. We originally proposed this study to the NIH, but the NIH is moving very slowly on thrombectomy-related trials right now. They're setting up what's called a big platform to collect a huge amount of thrombectomy data before they start randomizing again. So we then took the protocol to Genentech, who is funding the study, and we have about 48 patients. When I left for the trip, there were 48 patients who've been enrolled to this trial, and we were trying to get as many patients enrolled at the spoke hospital as at the hub. Because you can imagine the TNK gets a lot more time to do its thing. If you give the TNK at the stroke, TNK versus placebo, by the time you get to the hub, we're hoping that 20% of those M1 occlusions will be open. But even if you come to the hub, we want you to get the TNK versus placebo before you get the groin puncture. And the reason for that is that if you have a thrombolytic on board, there is some evidence that not only is it easier to get that TICI-3 reperfusion, but you clean up some of those small distal emboli. And really having 100% reperfusion gives you better outcomes than if you've got 80% reperfusion or 75% reperfusion. So that's why we think that even if it doesn't have a lot of time to work, it still has the potential to benefit. So here are the detailed inclusion and exclusion criteria for the timeless trial. And we're dropping down to an NIH of 5. Since we have M2 occlusions here, you can see we're sneaking down for milder and milder strokes getting in. And for the rapid criteria, it is essentially identical to a Diffuse 3. The ischemic core volume needs to be less than 70 ml. The mismatch volume has to be more than 15 ml. And the mismatch ratio between that ischemic core and the Tmax 6 penumbral area has to be greater than 1.8. In other words, you have to have at least as much tissue to save as is already irreversibly injured. You can get in with either MRI or CT perfusion, and the vessel occlusions can be cervical and or intracranial carotid, and then M1 or M2 occlusions. So this is a type of patient who would be timeless eligible. When you look at the green lesion, it tells you what vessel is occluded. You can see that that's the territory of the M1. So this is a patient with an M1 occlusion, and even if your CTA is of poor quality or your MRA is of poor quality, if you see the territory of an M1 or an M2 on the perfusion imaging, that's enough to get you in, because there's a very strong correlation between these perfusion patterns and the vessel anatomy where the occlusion is. And then you can see the CBF with its standard 30% threshold predicting a very small ischemic core. What about a patient like this? Would this be a timeless eligible patient? Well, this is a typical perfusion pattern for the superior division of the MCA, the M2 superior division occlusion. So it's got the right vessel occlusion. The problem here is that there's no mismatch. Right? You can see that this patient, all the area that's at risk of stroke has already gone on to die. So this is a type of patient that we would not include in the timeless study. If you do, that's the type of patient that's going to dilute the benefit. So I'm going to end here and say that the current status of late window IV thrombolysis is clearly in transition. This is a pivotal point where people are trying to look at that extend trial and the wake up trial and make a decision, should we be expanding our window for IV TPA? At most sites across the world, people are still sticking with that 4.5-hour window. But I think from the data that I've shown you, it's quite clear that in the future, we are going to be extending our IV TPA window probably at least to 9 hours, based on what we've seen in that extend trial and that the meta-analysis. And then if the timeless trial is positive, which we're very hopeful for, then we get rid of the time window. It's essentially the same thing that's happened with thrombectomy. Instead of having these arbitrary by-the-watch time windows, even for IV thrombolysis, we're going to be going by physiology. Who has salvageable tissue? We don't care the time. We care if there's salvageable tissue based on the imaging. And in addition to timeless, there are other ongoing trials. There's one in Canada called Tempo 2, which is also looking at TNK in a time window out to 12 hours. And then there's a wake-up study out of Norway looking at TNK called the TWIST trial. So over the next couple of years, I think we're going to be in much better position to get those 1A guidelines for late window IV thrombolysis. Thank you.
Thank you, Dr. Albers. Creo que esta presentación marca un poco el camino de hacia dónde va a ir el manejo del ACV agudo usando herramientas y usando fármacos que probablemente van a ir haciendo un camino más específico para cada tipo de paciente. A continuación quisiera presentar al doctor José Luis Manterola. El doctor Manterola es neurólogo y neuroradiólogo intervencional del Hospital Clínico de la Universidad de Chile. Tiene mucha experiencia y es un neurólogo que tiene la mirada clínica y neurointervencional, así que él nos va a hablar hoy día de disecciones arteriales. Muchas gracias.